cloud. So Mike Hansen can give you the record, okay? So first of all, if we have this document in the folder, Inspired Spine Health Policy, Protocol Policies, Process Formulary, then subfolder Protocols, subfolder 2022 Protocols. We have that so-called Operative Pain Management Protocol. And I'm going to open that first. Let's talk about that first. And in the next 2 months, we should get together and update it. So, and it makes sense. It starts with patient education. Okay, that they are going to have pain. They cannot expect not to have pain after our surgeries. And this is just operative pain management. We talk about the rest maybe later, okay? One of the things that they need to be extremely aware of, and everybody should be consented and talk about, that first of all, they will have pain. I mean, they cannot be having the surgery and not having pain. Second, that usually 3 to 5 days after the surgery, swelling gets worse and pain can get worse. And you would be surprised how many calls we will save if we educate the patient, let them know about that this is nothing is wrong, it's just a part of healing process. That I talk to patient before the surgery in my clinic, and everybody need to be on board on that to educate the patient about that. Third important thing is that they are well educated about the nerve root irritation. Most of the time it's not painful, but sometimes they can have neuropathic pain. And again, if they are prepared, it becomes so much more manageable to do that. And then intraoperatively, as you know, we use the combination of 1% lidocaine with epinephrine and 0.25 marcaine plain. We mix it half-half and use that for the skin. Usually about 10 to 20, sometimes 30 cc of that is used. At the end of the surgery, I always give a lumbar epidural steroid injection. I'm not sure, does Dr. Kim does it as well or no?
He doesn't do that. Okay,
I mean, it's okay if he doesn't do that. Sometimes in a difficult case, I just deposit 40 milligram of Kenalog in the paravertebral muscle just to cool down, because there is, see, one of our problem is we don't burn the nerves, we don't burn the muscle, we just poke a lot in them. This is like a first-degree burn. I hope you guys understand why first-degree burn is much more painful than a third and fourth-degree burn. Whereas in open surgery, we literally cook the tissue, denervate the muscle. Here, we just poke holes in it, but it's a pristine muscle with lots of holes in it. So that just cooling it down with some steroid is maybe not a bad idea. Don't have to do that, but I do it all the time. At the end of the surgery, one of these two is usually given. The Exparal, which is a good medication, like the cervical case we did in Crookston, went to the floor and was in horrible, horrible pain. And literally he was screaming and nothing else was helping. So what I went there, I just took an Exparal and I usually diluted 1:1 with injectable saline to extend the amount. And then I just went, I didn't even, I did not even take the dressing off. I put a ChloraPrep on both sides of the neck, just above, around the dressing. And then with a 22 gauge needle, like a 2-inch 22 gauge needle, I just went in and fan it out and spray it. Within 5 minutes, the pain was gone. His pain went from 20 to 4. He was the happiest person. Okay.
That's interesting. I wouldn't have thought to do that, but now I know. But yeah, there's no reason you can't do it post-op.
There is no reason you cannot do it post-op.
Yeah.
Right?
Mm-hmm.
Now, we can add it as well to our, if somebody, now the problem with Exparal is what, Dr. Aya?
It's very expensive. How did you get it? Very expensive.
I ordered it from pharmacy. Now, okay. Alternative to Exparal, you can use 0.5 marcaine. Okay? It is 1 hundredth the price or less, 1/300th the price of the Epidural. It doesn't last 4 or 5 days, but it does last up to 3 days. What you do, you just take it and you put small little deposit along the paraspinal muscle. And if you have a patient that is post-op and it's just the area of the surgery is killing them, is nothing wrong. Dr. Koch, make sure that we order 0.75 Marcaine. It is nothing wrong. What it is a trigger point injection, Dr. Koch. That's what it is. And you have done plenty of that, correct?
Yep.
So there's nothing wrong with just going now. You have to just clean it. You have to do a sterile technique because we don't want to introduce any infection in the area of the surgery. The good news is for our surgery, it is pristine, well perfused tissue. It's not the dead tissue that you go from outside inside into necrotic tissue. So the risk of infection, I think, is minimal, if anything at all. So, but I do that most of the time at the end of the surgery. In some places, they don't let us do Epidural. It's expensive. And truthfully, we shouldn't make it a routine to use. Let's make clear about that. We cannot make expensive things to a routine. It just will break the system. We should go with the most cost-effective way of treating pain, and 0.75 sometimes can help. Obviously, Marcaine rather than lidocaine because we want the effect to last. Then, post-operative. Even before patient wake up, they should get Toradol. And Toradol, as you know, it was it is like an aspirin, like aspirin. We thought it has effect on platelets, probably does a little, but not bad enough, and not by no means to a point that we would not give it. I give it to all my patients. Okay, so general is considered 15 Q6Rs, and I schedule it. Okay, and in some cases I use 30. Some studies say you're not really adding much when you go from 15 to 30, but in bigger patient, younger patient, lots of pain, I just go and double it. Just I think the psychological effect that you go in and you say I'm going to double one of your medication has been very effective. Now we have to be careful with that, with the elderly and so on, but I do it maximum 2 days. So I have had zero adverse effect from it. Okay, so officially you can give it up to 5 days, and but I give it only for 2 days in the hospital. Most of the time, not even two days, because they are discharged long before that. Giving it as an outpatient pills is a possibility. We don't utilize it very often, but if you do that, give it as well for maximum 3 to 5 days. Never more than 5 days, preferably 3 days. Please, Dr. Aya, add that to our for the post-operative, that could be well, it is already there, as you see. So now post-operative. So we talked about the Toradol. All of our patients should get Visceral. I wasn't a believer, but over the last 10 years, I have become a true believer in Visceral. It's an anxiety medication. It just reduces their anxiety, the level of, pain is an emotional response. It just calms them down and reduces the amount of the narcotic they need. Now, there is 2 formulations of Visceral, 2 different, what is attached to. Not Visceral, the hydroxyzine. The Visceral, is a formulation that comes in 25 and 50. Again, I started on 25 and I schedule it. Here it says, as you see, not PRN. I schedule it, but again, if it's not enough, just the emotional effect, the psychological effect, you go there, you promise them you're going to do something for them, and you double the Visceral. That very effective. Now, there is another formulation of hydroxyzine that comes in a different, like I think one of them is a acid, the other one has a different ligand attached to that. That comes in 20 and 10 and 20. Okay, I don't care which one, whatever hospital has, I think it works. Okay, but one of them is visceral, the other one is not visceral. Dr. Aya, can you check it out and correct that, please? It's hydroxyzine, and visceral is just one of the formulation of it, brand name.
It says it looks like hydroxyzine pamoate is the generic, and Visceral would be the brand name.
No, but they have had, one of them is hydroxyzine, has a smaller molecule, HCl. The other has a bigger things. So 10 of one formulation is equal to 25 of the other, because the ligand is attached to that, is a bigger ligand. It's just, but the hydroxyzine is the active thing. I don't believe the action is any different. But Dr. Aya, find out. I don't have any preference.
So the pharmacists, because at Riverview is the only place that I've come into that, because they have both, but the pharmacist at Riverview said don't do the one with the HCl because it's not really, it doesn't work the same way as your normal visceral. So if you type in visceral, you'll get the brand name, but you'll get the pure version of it without
the visceral, is that the one that with the 25 and 50, or is it with 10 and 20?
25 and 50, yes.
Okay. Can you then correct for our next things? Just put the information in this protocol and then update it for us, please.
Sounds good.
Okay. And again, I told you where those protocols are.
I need you to share it with me, but I don't
share. It is all, it should be already shared with you.
Okay.
Okay. To talk to Christine or Tara, they have the original because they act on it. And as well, Mike Hansen disseminate this with other surgeons that we work with. Okay. So visceral scheduled, toradol scheduled, as well as a muscle relaxant scheduled. Now the muscle relaxant that we use is either Flexeril or Relaxant. Okay. And I'm sure there are some other muscle relaxant, but this is what we have most experience with. As a matter of fact, I just 2 years ago started using Relaxant with pretty good results. So, and as well, I schedule it. Here you see that it says Flexeril PRN. Please go ahead and change that to not PRN. I think muscle relaxant, especially when you poke holes in the muscle, is something that can, with a very low profile for the risks, can be scheduled. And I get it, you know, in Riverview, it comes 10 to 12, but 10 to 8 is a good formulation. Robaxin, I start 500 is a good place to start, but usually they end up with the 750 as well scheduled. And these are, muscle relaxant is the last thing I take them off. Okay. Now, gabapentin. Gabapentin is a very effective, and as you know, for neuropathic pain, and traditionally has been used for neuropathic pain. Having said that, it seems that has a pain modulation effect, and this is just in the meeting. There's a good pain group in Fairview Ridges, and the head of them is actually the nurse practitioner, who is the head of the Minnesota Nurse Practitioner Association for Pain Management. So that was what we learned from her, that it's not a bad idea to give perioperatively some gabapentin. Usually, and that's not the 900 TID dose, and I'm talking about a very low dose, sometimes even 300 daily or 300 TID. That is the pain modulation effect, is not a neuropathic pain dose. Dr. Coach, what is the neuropathic pain dose?
The maximum dose is 3,600 a day.
3,600 a day is the maximum dose, but most of the time we use
300 TID.
Well, 900 TID is the regular dose for neuropathic pain, which makes 2,700, but you can go to 1,200, the maximum dose. If you do that, there is a protocol we have put in place. There is 2 different protocols. In the hospital, they are in the bed, you check the neurovascular, you check the vascular system and the blood pressure and so on. You can go up faster, but outside of the hospital where you are not controlling them, Dr. Aya, how would you start neuronting for somebody that you are not having access to every moment? They are not under your control. How do you do that? We're not hearing you. You're muted.
Gabapentin, I started on 300.
So,
And then every 2 weeks, I evaluate them because it takes a while for them to actually get a loading dose.
well, this is our protocol for gabapentin. If you are not in the hospital, we start with 300 the first day, and then they can watch themselves. Second day, we can go to BID and then TID. As you see, this is a slow increase in the dosage and checking for. In the hospital, you can go much faster than that. In the hospital, you can start 300 TID, and then next day you check the cardiovascular thing, and then if they are stable, you go to 600 TID and 900 TID within 2-3 days. But the slow increase is visualized as well as in our protocols. We put it on based on lots of experience. If you have new evidence that says you can go faster or shorter, but let's do it for a reason, okay? If this has been working for us pretty good, we have never had somebody had to go to ER because they lose their cardio orthostatic kind of function and so on and so forth. So we can modify it as we go, but this is our current protocol.
Yeah, I like it, Dr. Abbasi. I want to ask you a question about it. Can what we like to do sometimes is, especially if they're having trouble sleeping at night, is adjust the dose that they're taking more before they go to bed. Is that something you're comfortable with? If we do it in this, tell them just take an extra, or not extra, but keeping the same daily dose, but make it so that you're taking less in the morning, less in the afternoon, so they'll stay awake, but more at night, because that's a typical side effect.
Yeah. One of the problem I have noticed that if you change the dosage, that is multiple different doses, that confuses the hell out of lots of elderly people.
True.
The compliance goes, and that across the board has been shown that if those doses changes during the day, like 2 pills in the morning, 1 pill in the noon, 2 pills in the compliance goes so far down. We are not dealing with lots of people who are adequately, like educated and just conscious about things. So when the need arises, like if somebody does have a problem with the sleeping, then we can individually modify it. But for most of the cases, let's keep a very easy, simple kind of
that makes a lot of sense. Yeah.
So let's go back here. Then let's go back to our. Where did that go? Here. I lost my thing there. I'm going to open it again because pain management here. Okay, here we go. So we talked about the total. We haven't talked about the IV. We haven't talked about that. We have talked about the flexor or Relaxant, Visceral, Gabapentin. Now, let's go to the narcotic now. So we have 3 medications that are scheduled: total, muscle relaxant, visceral. The narcotic always maximize first the PO because they give you a steadier dose, and then the IV. Now, Dr. Arya, what pills, POs are we using right now? Yeah.
Norcos 5, 10s, and Percocets 5s or 10s, Q4.
And obviously Norco hydrocodone doesn't come as an individual thing, but oxycodone does come as an individual thing. Meaning that we start with, I like to start with Norco. It has a good balance. And if it's not enough, then I go to Percocet, oxycodone. If 10s are not enough, then you're maximizing the acetaminophen. Then I go to oxycodone, oxy-IR. Does that make sense why I'm doing this? You can go up and then you maximize the acetaminophen part of it, and then you go to plain oxy-IR. The very last that I like to use is dilaudid pills. And again, like anything else, is about the graduation. We know stronger narcotic have stronger side effect. Like before we had the open, before we used to do OLEF, we had like up to 25% ileus, 15 to 25% ileus. Not all of them are, you know, the form that you have to take them to the OR, obviously. But our rate of, we have 1/10, I don't recall on top of my head how often we had ileus with OLEF patient. The reason for that is we use less narcotic. That's all what it is, okay? So I like to use the least amount of the narcotic as possible. And that least amount, the graduation, you know, there is a equivalent dose to morphine, right? Yeah. Like those doses are well established. It goes from the codeine to, I think, how is it? Tramadol, codeine, in that goes up. Tramadol, codeine, hydrocodone, oxycodone, hydromorphone, correct? Dr. Aya, why don't you, for the next meeting that we are going to have those and the morphine equivalent dose of them available, because we have to do it eventually. Dr. Coach is going to start educating himself to become a person to go for this kind of, because when we are trying to wean them off, that is what we use, the morphine equivalent protocols, and those are well established. So have them available. We will start educating ourselves about that even more. And by the way, Ethan, I think this doing it in practice, like what we are doing now, having a group with pain specialists, interventionalists, chiropractor, physical therapist, surgeon, and you, that is way more valuable you going than to one day in a course somewhere, just writing down things. We are doing it already. Let's maximize. Let us be the people who people come to get trained.
Oh, okay. Yeah.
You will be in charge of that. One day you will be. Okay. So, but establish those morphine equivalent doses. But that is the reason I usually, and I don't start with tramadol or codeine in the hospital, because I need something fast acting and something, you know, a little bit bigger of a gun. But some people, like elderly who are barely in pain, when I start them on hydrocodone or Norco, doesn't mean that I cannot go up, doesn't mean I cannot go down. It is just a safe place to start. And the safe place to start for me is 325 Norco every 4 hours. Then if I need to go up, I do 325 every 3 hours, but then they max the acetaminophen part of it pretty soon. But then I go to 10 325s. Same, 10 325s, you can go even to 3. If that's not enough, we go to oxycodone or Percocet, 5 325 and 10 325. Then we go to oxy-IR. We can go from 10, 15, 20, and you can do 1 to 2 taps. And the idea is 1 to 2 taps is not giving 2 taps. And that is a conversation. You guys don't have to fight it, because we fought that long time ago. The pain medication is not PRN for nurses' comfort. Okay? This is, you would not believe how non-trivial this is, because this patient comes with pain, right? They are painful to themselves, they are painful to all the staff, and the nurses, they just want them quiet. Yep. Sometimes to a point quiet that they stop breathing. And everybody who has done what I'm doing knows that happens still in the United States every day, that people quit breathing because, as you know, we create a tolerance to all effect of the morphine receptors except our breathing. That does not develop any tolerance. So when we write 1 to 2 taps every 4 hours, it's you give 5 milligram. It's not, otherwise we would have written 2 taps, right? It's 5 milligram. You watch the patient half an hour. you reevaluate the patient, and this is what I tell the nurses. Patient need to be able to look at you in your eyes, have a full sentence before they receive any narcotic. Okay? Practically, we summarize the function of the PCA, patient controlled anesthesia. We talk about it later. Okay? So practically, the nurse has to reevaluate the patient before giving any narcotic, and 1 to 2 tabs doesn't mean 2 tabs. It means 1 tab, wait, reevaluate, give the second tab. You don't have to fight that, because we had that fight after some patient unfortunately didn't make it. Okay? So this is not a trivial thing. So then but the graduation goes as well the backward too. Like, if they are too sedated, we stop it, we hold it, and then if next time they have pain, maybe we give codeine, maybe we give tramadol. 50 milligram of tramadol is a good dose. Okay? And going up is based on what they are used to, and based on what they have been receiving, can go as high as, like doses that a normal person wouldn't tolerate. But I have a patient who get 20 grams of oxy-IR every 3 hours. Okay, but if you go gradually up, but if you get anywhere above 1 to 2 tab of oxy every 3 hours, you have to put the patient on what, Dr. Aya?
Telemetry.
Correct. You have to put the patient on telemetry, because what happens? Their drive for respiration goes down, their respiration rate goes down, and you have to be in a place that as well, you should be able to reverse it with, reversal. I hope I don't need to explain to you how the reversal goes. It's very straightforward. One of the downside of giving Narcan is it reverses all the effect. So
Everything.
they wake up in pain.
Screaming.
Or horrible. But I rather them be in horrible pain than comfortably dead. Okay? So you have to have an environment that it's trained to use it, the judgment. And one of the things, Dr. Koch and Dr. Aya, you have to be very careful with is, we have a lot of patients, if you ask them how bad your pain is, it's going to be always 20.
Yeah.
They look at you with a smile, you see the smirk in their face, and they say their pain is 20. So one of the things you need to train the people you are training to use this is that giving the PRN part of it has a huge amount of personal judgment, medical judgment. It's not like patients say pain is 7 or 10 and automatically next dose is due. Obviously, looking into your eyes, talking full sentences is a major part of it, that their level of awareness is adequate for the next dose. But beyond that as well, especially the younger people, nurses, they just put 7 to 10 another dose. Even if patient is sitting there shoveling the pudding and just having a conversation, and many of these patients will push you. Okay, so you have to be using a medical judgment to give that. But once you do that, we won't let anybody being truly in pain. Pain is a visceral reaction, right? Blood pressure goes up, heart rate goes up, and they're sweaty, they're clammy, and so on and so forth. We should know what pain really is, and that pain we always treat. Okay, we don't let the patient, like that patient last night, he wasn't just just screaming to get attention. He was calmed down, he was sweaty, his blood pressure and heart rate was going up. And then, and I didn't start with narcotic. You just have to use your judgment. That trigger point injection with the Epidural beautifully worked. So Many of these patients, they come already with long-acting narcotic. We have pain specialists that they calculate the morphine equivalent dose, and then we combine it in our pain management. In the next meeting, we should actually invite the pain specialist from Fairview Ridges. Dr. Aya, take charge on that. Her name, you can get the name offline from me, or our office should have the name. Maria, we had a meeting with them before. Let them be with us. They benefit from our experience, and we will definitely benefit from their experience, okay? But they can help us to calculate the morphine equivalent dose and see how we are going to do. Like, there are some partial agonist antagonists. They have the expertise to how to deal with those special medication, okay? And we should develop our own protocol for that, Dr. Coach. That is your domain now. You should learn from their experience, and then based on that, take it a step forward, actually. Many of our patients that are having a long-term narcotic, they are going to pain management in the university. Dr. Coach, connect to them. That will help you learn way more than somebody who just put some slides on the wall. That is actual people who are doing it, and they have offered us. All our patients are supposed to go there. Maria knows because we were connected to them through Dr. Frechette from Fairview Ridges. Connect to them and play an active role in their management. They have all the expertise. You just try to acquire their expertise and pass it to the rest of us. Any questions so far?
So Maria has the name of who to go to for that?
Yeah, there's a pain specialist group in the university. And Maria is supposed to send our difficult patients to them, connect to them, ask them to come us and give us an in-service. And then this is good. This is peer-to-peer. They get our patient, and they should explain to us how they do their magic, and let us learn from that, okay? Connect to them personally and ask them to give us an in-service. They will be happy to do that. And that's the best peer-to-peer that we can do. Their group with our group, they give us an in-service about what they do, set up a meeting, 1 hour, half an hour, they give us an in-service about their magic, half an hour, we give them an in-service about our magic. So, outpatient. Many of the things we talked about here, they carry over to the outpatient. Like, you remember we talked about those Norco and so on. Let me make it bigger here. This is the same thing now in a different kind of thing. You know, here we have people who are barely on any medication. We can just start on Norco, 2 tabs, Q4 hours, then go to Q6, then go 1 tab Q4, and then 1 tab and then stop. That's a very fast. And somebody who had just a disc herniation, got a surgery, and usually within most of them, they don't even need to go that far. Usually they stop here or here. Barely they go more than 4 weeks. But we are not always that lucky. Sometimes we get people that need a little more attention. It's like we start with Norco 10s, then you see it gradually, very gradually. That is our weaning protocol. I developed this protocol because I got together with somebody who does a lot of this kind of weaning the patient, addiction, you know, management and so on. And we developed based on this is based on how much patient's requirement is. You find that, and based on then assign them to one of these circles. Like this patient requires higher to start with, but then we go gradually down and we stop. You see, that is 10 weeks. That's a long time. Okay, but unfortunately, we have patients that even that's not enough. Okay, so some patients come, you see the color changes. So we put a lot of expertise on this. I didn't wake up and just make this. I need you to understand that. So I need you, if you are going to modify this, to spend at least as much time I spend on this to modify it. It's not a gut, this is not a gut feeling. I just woke up and I draw some lines and so on, okay? If we got in a group together and we developed that, you see here, we're starting with something more, Percocet, but eventually we go down, and at certain point, we can change it to lower narcotic, and then we go very slowly and then stop it, okay? We still, just 1 week more than this, but we go from higher level to lower level. And, here you see that this patient is getting 20 milligram, and the path here is obviously going to be longer and slower. The idea is like, have you heard about that method to reduce the salt intake for people when they have heart problem? The internal medicine and cardiologists, they prove that if you try to get the salt away from them, the compliance is almost zero. The food becomes so bland that they just stop. But what they do something very similar. They reduce the amount of the salt in their intake so little that from 1 week to another, they don't notice much of a taste difference. Then the compliance goes like significantly higher. Like the perception, this is the perception that the amount of the changes are so little, and you coach them in that process, okay? And this is the 3-month wean. Still reasonable for somebody who has been 10 years on narcotic, okay? So this is what we developed, is nothing set in stone. This is my signature from almost 2 years ago, or 3 years ago. Soon to be, almost 3 years ago. So nothing says we cannot change that. But we change it based on actual information, data, experience in a multidisciplinary group. Until we do that, just adhere to that, has helped us, and our nurses are using that. When a patient comes and they're fallen, they see which group they belong to first, and that in that circle, they go 1 step forward or backward. And that is a standing order here. As you see here, like a patient, we know this patient has been in the moderate high group and comes out at here. Unfortunately, he fell, he has more pain, we go 1 step back, but then we resume that step forward. Does that make sense? Okay, that is our narcotic outside of the hospital. Any question regarding that? No? Okay, now that has nothing to do that narcotic is almost never the only medication we give, because we know in combination with muscle relaxant and visceral, and if they fell, if they have an acute event, even maybe you can give them another, a few days of Topical and so on. We know that in combination, and as you know, Topical, IM or IV always works better than pills. As well, I think part of that is psychological effect of it, but in combination with the other medication. Now, another useful medication that can sometimes help is Lyrica. Dr. Coach, have you any experience with Lyrica?
Very little. We tend to use Gabapentin more. Yeah,
it's again, same kind of idea about the pain modulation. Sometimes they react to the Neurontin. Sometimes it's just actually additional in addition to Neurontin, but it works in some group of people. It works. Now, all of that is nothing to do with the nerve irritation that we encounter sometimes. Okay,
Mhm.
At nerve irritation, let's go talk about that in a second. But after certain, there is a Minnesota risk assessment. There's a database that we check if they have gotten 5 other medication from 5 other people and so on. We have to check. Our staff is pretty good. You don't have to do that because we already have established that they call to wherever they get their pain medication, other place, and they coordinate that with that and so on. But all of that, we have to be on board, and you check their pains, the risk score, and if it's above 450, you just have to give them as well a prescription for Narcan, which is intranasal, right? You just empty it in the nose, and you train them how to do that. That has changed the safety profile significantly. Now, any questions regarding the regular pain management before I talk about the nerve irritation? No? Okay. The nerve irritation for our OLIFs, Dr. Aya, can you describe what it is and what percentages are there?
So the percentages that I remember seeing is 15% have a.
No, that is what we consent them for. That is not the risk profile. And it is not pain mostly. It is just the nerve irritation.
Yeah.
No, we separate them in nerve irritation and neuropraxia. Nerve irritation, we call it sensory deficit and weakness down to 4-. Neuropraxia, we define it in our study, neuropraxia, the weakness 3 and below. Okay, now in the first study we published, and that had our actually my learning curve. Okay, I compared the OLIF to TLIF, my TLIF. The problem with the TLIF is they are so miserable. The numbness on top of their left foot is their least problem. So, but if we did a methodical data collection, we found out TLIF has 12.4% risk of nerve irritation, TLIF, and OLIF has 8.5% risk of nerve irritation. Okay, the reason we consent them for 15% is because that risk is much higher for what level, Dr. Aya?
5-1.
5-1, because of the angle of an attack. So that risk is about 13-14% in my learning curve for 5S1. And that is why we are consenting. There's nothing wrong with consenting them for higher and have better results, right? Rather than you say nothing's going to happen and everything happens. It's time in our 1,000 patients, we are going to have a new numbers established. It's up to you to establish them. So the risk of the nerve irritation overall is about 8 to 9%, but for 5S1, that is much, much higher, right? And then not all of them, most of them are just the sensory, numbness, tingling. Now, if they have numbness and tingling, you need to educate the patient and you need to know it and you need to prepare the patient. What happens, Dr. Aya, when you sleep on your arm and it goes completely limp when you wake up? Describe what you feel after that.
So usually when you remove the compressor on the nerves, then you start getting the pain sometimes.
No, well, I want you to describe, have you ever slept on your arm? You wake up, it's practically completely numb. And
yeah.
There's a literally temporary compression of the nerve. Describe to me what you feel stage at stage at stage at stage. What you feel?
Me personally, I don't.
Never had that?
No.
Wow. Dr. Coach, have you ever slept on your arm and it completely go numb? Practically, you wake up, you're paralyzed. Your arm is paralyzed. Describe stage by stage with the timeline. What happens then?
Okay, so the first thing you do is freak out because you can't move your arm at all, and you can't, and then you kind of, and then I think it's almost involuntary. You kind of try to shake it a little bit and hopefully, sort of wake up a little bit. If you can't do that, you might actually have to use your other hand to do it. It's really scary.
Yeah.
But then what happens is then I think this is what Dr. Aya was alluding to, after it's probably usually seconds or maybe a small number of minutes, you start getting like some kind of paresthesia feeling down the arm,
Like it just feels strange.
it feels weird. It can be painful, like
When
pins and
it feels
needles.
strange. What do we call if paresthesia is one word, there's another word when they feel strange.
Dysesthesia.
Dysesthesia.
Yeah.
Okay, so paresthesia, dysesthesia, and then what happens then?
You start getting that sensation, and eventually that also probably only lasts for
just before you get the sensation back. What do you get? Pinprick and jolt. You feel like sometimes almost like electricity shoots down the arm to the finger sometimes, and then as well they start tingling. It usually lasts few seconds, but then few jolt, you goes down, and then it becomes all normal.
Yeah.
All of that usually takes about how many minutes?
Just a couple of minutes, probably at the most.
About 3 to 5 minutes.
Yeah.
Have you heard the word, the lover's arm?
Sweetheart palsy. Yeah.
Sweetheart palsy, lover's arm?
Yeah, sweetheart palsy.
What is that, Tataya?
It's when women sleep on men traditionally, but now everybody can sleep on everybody. And then the guy's like puts his arms around her and his arm falls asleep because she's sleeping on the basically it's an ulnar nerve palsy because he's being shivered.
Well, most of the time that's not the mechanism. Even though we call it sweetheart palsy or lover's palsy, the true mechanism is people get drunk, they lose their reflective protective reflexes, and they are somewhere on a bench and the arm is over the bench, it's right here, and then that usually have as well a good prognosis, but it doesn't take few minutes to go away. How long does it take to go away? Or give me a little clinical information regarding that.
So that's Saturday night palsy.
Well, that is Saturday night palsy, but which is a practice same mechanism like a lover's palsy or a sweetheart palsy and so same. Well, but how long does that take to go away?
That can take months, weeks or months to go away.
Weeks or months away. Yet, and here you receive what we have with Olaf. So Olaf is practically a form of Saturday night or lover's palsy, an extended form, where those stages, but they go through the same stages. So when the patient comes in scared and you freak out, I love that you said that, Ethan, okay? Freak out, it is like sharp, it's burning, like it's going down like electricity. I'm so scared. And my answer to them is, you remember we talked about that? That means that nerve is waking up. That is a good sign. That is like itching for a wound. That means that, so when they know that's a good sign, all of a sudden, the whole psychology of that changes. You would be surprised once you prepare the patient for that. And when they come, you turn it just around. They come because they have a burning thing going down their arm. It's scary for everybody. But now you tell them this is a good sign, meaning that nerve is waking up. And that can be, usually I'll tell my patient that jolt, that burning, that for a few seconds, that's what it is. It happens about 4 to 8 weeks after the surgery. That is when the time frame usually comes. Sometimes it comes sooner, sometimes it comes later. And there's a characteristic thing to that, what we talked about. It is few seconds, it shoots down, it scares them, and then it goes away. And that is when, when you have truly, you guys are familiar with the stages of the nerve damage, right? In one of those stages, like, axonoematis, that, sometimes the actual axon, they're disconnected. When they reconnect, that is when you get that shooting signal. And we have like thousands of them. So it makes sense that you get again and again and again the same kind of feeling. And it starts that they come a month after the surgery, they still have it in their thighs, but then 3 months later, the thigh is fine, but they still have it below the knee. And then 4 months, 6 months later, they still have it just on top of the foot.
Mhm.
Now, in our study, only 1 patient in 303 patients had still meaningful deficit after 1 year, which makes it 0.3%. By the way, for TLIF, that has been recorded all the way from 0.3 to 35%. Most of the places, 1 to 5% is acceptable. And that those studies that have been less than 1%, they were very, very selected group of people, selected very lots of selection bias in very experienced hands. Okay, so our result is equal to the lowest ever in the literature reported. So we are very good. We should be proud of that. Okay, like when was the last time you saw any of my patient with the neuropraxia? Oh yeah. Remember, on top of your head, anybody?
No, not really.
I saw a patient about a month ago had the still, but it still was 0. Now it was 3 a month ago. It happens. It just you just have to know the statistic and work on that. If it happens, gabapentin is something we use for that very specifically. What else we use for that is obviously pain management, but gabapentin is good, Lyrica is good. These are made for that. That is where I go with the gabapentin to higher dose. And as well, another things that works with this patient very well, like make magic for them if they have pain, not for numbness, obviously, right? We don't give pain medication for numbness, but we just talked about you can have pain. If you have nerve irritation, part of nerve irritation can be other sensory, but part of that can be pain. For the pain, gabapentin, Lyrica, other pain medication as usual, Visceral can help as well. But there is another procedure we do for that, the nerve root, selective nerve root injections. Okay, so if you have somebody with the typical L5 nerve root symptoms, nothing wrong with doing this L5 nerve root injection in the L4, in the L5S1 foramen, and just infiltrate everything, and that can really make their day. They come with a horrible pain going to top of the foot, but then you numb up that nerve and they walk out of that place and as happy patient, okay? So include that in your treatment if needed. But then you have to exactly know that this is a selective nerve root that's causing their symptoms. Any question regarding this?
It's slightly off topic, but I'm just curious, what's your take on capsaicin cream, that sort of thing, like for nerve irritation?
Well, I can tell you what I have read so far about it. It works by no, I think the mechanism how you're talking about local cream, right?
Yeah.
It works the same way TENS unit works. By you see that there. What we found our spinal cord stimulation device. We know they work, and the way they work, they like imagine somebody comes with the bad news to you, and that bad news is pain, right? Now, I know that person with the bad news is going to come to you, and I come to you, and I just distract you. I just literally, I come to you and I talk your head off. By the time the person comes with the bad news to you, you are so overwhelmed with the stimulation that bad news doesn't really register the way that if you were bored and looking for problem, and that bad news, and by the way, there got some good studies that acupuncture works the same way. That you stimulate the nerves above the level where the pain signal will come, and you, by overstimulating them, you increase their threshold that they need to register, meaning that if I overwhelm you and the person with the bad news come with the hammer, hit you on the head, you still will get the message, right? So if the pain signal is strong enough, you still passes through. But by me overwhelming you, you pay less attention to that amount of the pain as if you're just sitting bored there waiting for some signal to come. So yes, it works, and I have no objection. Just stay away from area of the surgery.
Yeah.
Okay, because that area, especially within the first few weeks after the surgery, does not need any more irritation.
Yeah.
And we all know capsaicin is an irritant, right?
Yeah. Yeah.
Okay, just as long as we stay away from our incisions and area of the surgery, be my guest.
Okay.
Anything else? But that was a very good question. And as well, epidural steroid injection. Your capsaicin comes in that category.
I see. Yeah.
Topical anesthetic and intramuscular injection and so on. That intramuscular, it has to be intramuscular. Like, if you don't know where intramuscular is, get an X-ray. Get double X-ray, okay? But don't put it in the fat tissue because it's just going to do nothing for you.
Yeah.
Don't put it in the spinal cord either. Well, everybody will be unhappy, okay? If in question, we have X-rays, utilize it. Maybe someday we can even get an ultrasound, okay? They're not that expensive anymore. So you see my signature here, and this is recorded, Dr. Aya, based on what we just talked today. I want you to go and update that